Diagnostic Cystoscopy. Cystoscopy is the surgical procedure using a rigid or flexible fiber optic endoscope to examine the bladder. Urethroscopy is a direct examination of the urethral lumen for urethral diseases or abnormalities. Cystourethropy is the endoscopic procedure that visualizes both the bladder and the urethra. Indications for cystoscopy can include the ability to rule out a bladder injury, which could occur as a result of surgery and result in leakage of urine either into the abdominal cavity or the vagina. Examination of the interior of the bladder can rule out the presence of a foreign body in the bladder or the urethra, such as a stone, suture, or mesh. Cystoscopy can be used to confirm ureteral patency and also verify the correct placement of a suprapubic catheter. The basic equipment for cystoscopy includes the cystoscope itself, a bridge which may or may not contain an operative port, and a sheath which will contain a port for influx of fluid and outflow of fluid, as well as a bevel at the end of it which will minimize trauma while the scope is passed through the urethra and into the bladder. A variety of different types of cystoscopes can typically be found in the operating room. To best examine the bladder, a 30-degree or 70-degree rigid cystoscope will offer the angles necessary to examine the bladder in its entirety. To examine the circumferential nature of the urethra, a 0-degree or 15-degree cystoscope is best utilized for this endeavor. In some cases, when examining both the bladder and the urethra, it may be necessary to switch between a scope whose angle is best utilized to examine the bladder and a completely different scope with a more direct angle to examine the urethra. Examination of the bladder. Diagnostic cystoscopy is often performed by physicians to evaluate the bladder. However, it is not always performed in a manner that is consistent and reproducible from patient to patient. A methodical approach to examination of the bladder should be performed each time the cystoscopy is done to avoid an irregular or erratic pattern of examination of the bladder. Regions of the bladder to be examined. The bladder can be divided into several areas beginning with the urethra, which is subdivided into a proximal, mid, and distal portion of the urethra. Within the bladder itself, the trigone can be examined, in which the ureters will be identified. Neighboring the trigone is the hemitrigone region. This includes the mid-hemitrigone and lateral regions referred to as the left lateral hemitrigone and right lateral hemitrigone. Beyond this is the bladder dome. It is important when performing cystoscopy to examine each of these areas. Performing a bladder survey. With a better understanding of the locations of anatomical structures within the bladder that need to be examined, a consistent and reliable survey can be performed. Here, we've begun at the base of the bladder and move in a cephalad fashion along the mid-hemitrigone and then up to the bladder dome. Careful attention is made to stay within a few centimeters of the surface of the bladder to allow for adequate assessment of the bladder surface. After having gone from 6 o'clock to 12 o'clock, the scope is then passed from 2 o'clock to approximately 7 o'clock. The cystoscope is then diverted to the 4 o'clock position. Once we've reached this point, we will then proceed from 4 o'clock to 10 o'clock. After having viewed these multiple angles, we will complete the bladder survey by beginning in a 3 o'clock position and proceeding to a 9 o'clock position. Once this is done, the survey of the bladder itself is complete. The trigone can now be examined. The ureteric ridge can be identified, as well as the ureters. Examination of ureteral patency can be performed if indicated. The procedure is completed with an examination of the proximal, middle, and distal thirds of the urethra to rule out evidence of pathology within the structure. Common cystoscopy findings. The appearance of the normal urothelium is somewhat of a pale appearance with fine arterial and venous blood vessels. This is in stark contrast to a bladder that has hypervascularity, as shown here in this image. Hypervascularity itself demonstrates an increase in the presence of both arterial and venous blood vessels within the bladder. If the reason for such pathology is unknown, a bladder biopsy may be indicated. In some pathological conditions such as interstitial cystitis, a gathering of capillaries may be demonstrated as shown here, which is referred to as a glomerulation. If one is not entirely certain that this is a glomerulation, it too should be biopsied as a precaution. A lesion growing from the wall of the bladder should be biopsied with the anticipation that this likely represents a carcinoma. A lesion such as this with a grape-like cluster of cells typically represents a transitional cell carcinoma. It too should be biopsied and treated. Squamous metaplasia is a common finding which is often located within the trigone itself. This is an overgrowth of the cells that make up the trigone. Occasionally a clear cyst, referred to as cystitis cystica, can be found in the trigone and represents a benign finding. Should the squamous metaplasia detach from the trigone, it can be seen as little floating particles within the cystoscopy field, referred to as exudate. Beyond the trigone, occasionally lesions can be seen on the hemitrigone and bladder dome areas. These can include plaques, which can be associated with bladder infections, or cysts, which may be opaque. An opaque cyst is referred as cystitis glandularis. The cause of this cyst should be determined. Oftentimes this may be because of recurrent bladder infections. However, if the reason for the appearance of such a cyst is unknown, a biopsy may be warranted. Hypertrophied detrusor muscle within the bladder is referred to as trabeculations. This oftentimes can be seen in patients who have an overactive bladder. It can also be seen in patients with outlet obstruction. Occasionally scar tissue from prior cystotomies can also be seen as shown here. An inflammatory reaction found at the bladder neck or at the proximal urethra can be seen. This is referred to as a pseudopolyp or a front. It is a benign condition, and in many cases can be an inflammatory response to a recent bladder infection. Confirmation of ureteral patency can be an important part of cystoscopy. The vigorous efflux of urine from the ureteral orifice can assure the physician that the ureter is patent. The presence of sluggish flow of urine may be normal and not evidence of a blockage, but also could be due to a partial obstruction from the patient's surgery, a kidney stone, or a possible stricture within the ureter. Vigorous flow of urine from the ureteral orifice demonstrates no evidence of current obstruction, but postoperative swelling neighboring the ureter could cause possible obstruction and warrant workup if suspected. The benefit of cystoscopy for assessment of ureteral patency is further highlighted for a patient who has recently undergone a cystotomy repair. In this instance, confirmation of ureteral patency is an important component of this patient's intervention for cystotomy that was repaired during a hysterectomy. The administration of indigocarmine dye following completion of the repair further confirms the patency of the ureters. Had the indigocarmine dye been given during or prior to completion of the repair, the presence of the indigocarmine dye may not necessarily confirm complete patency of the ureter. Confirmation of bladder integrity is in some cases, such as a TVT sling, a required component of incontinence surgery. While this is not the case with other types of incontinence surgeries, the surgeon still benefits from assessing the bladder to ensure that a foreign body, such as this birch suture from a prior urethropexy, has not compromised the integrity of the bladder. Having been discovered at the time of implant, this suture could have easily been removed. However, in this event, being discovered some time after her original surgery, operative cystoscopy was required to remove the stitch. The site from which the suture was removed can be seen here. Management concepts. A small sheath, such as a 17 French, may allow easier passage through the urethra and into the bladder. Larger cystoscope sheaths may be difficult to pass and potentially traumatize the urethra. A 70-degree lens offers less manipulation of the cystoscope itself to visualize all aspects of the bladder compared to a 30-degree or 15-degree scope. The use of pressure bags with IV fluid could possibly rapidly overdistend the bladder and cause injury to the bladder and should be avoided. Obscured views of the bladder wall itself may be due to excess sediment, blood, or IV dye. By simply filling, emptying, and refilling the bladder as needed, this will allow the surgeon to get a clearer view of the urothelium. The administration of IV dye, such as indigo carmine dye, only after the surgical procedure is complete provides a clearer confirmation that the ureters are patent compared to if having been given prior to or during the surgical procedure itself. In the event there is an absence of efflux of urine from a ureteral orifice or sluggish efflux of urine, patency can be further assessed by either passage of a ureteral catheter or intraoperative intravenous pyelogram. Tips and tricks. By performing cystoscopy on patients who are not suspected of having pathology, this will allow you to improve your skills when needed for patients who do have bladder pathology. If a bladder laceration is suspected, closely inspect the mid-hemitrigone as the most likely place of the bladder injury. It is still important just the same to inspect the entire bladder. Light cords are frequently damaged. As a result, visualization can be greatly impaired. Change out your light cord as you need to. If you intend to perform office cystoscopy, consider the use of a flexible cystoscope which can enhance patient comfort while the patient is awake. The performance of routine cystoscopy in gynecological surgery can improve the physician's ability to diagnose intraoperative pathology or discover pathology not suspected in an otherwise healthy patient.